Welcome, everyone. Welcome, everyone. It's nice to see you all today. We are going to be talking about helping kids navigate behavioral health through telehealth in Northeast Minnesota. Today, I'm here from Wilderness Health. Wilderness is a collaboration of 9 independent healthcare facilities across the region, and we like to find ways to work together with our region to understand the needs and also connect with providers who can help meet those needs. So you'll also hear from Carrie Rango of True North Psychiatry, and Shauna and Stephanie are both here from Charlie Health. And both of these folks have kind of a unique interesting ways of being able to help pediatric patients navigate behavioral health through telehealth. Um, I would imagine that some of these needs and opportunities are not very different from some other rural areas. We do have lower ratios of mental health care providers. All of our region is in a health provider shortage area when it comes to mental health, and there are long wait times. Um, Mostly rural and remote. And we also have more kids who are living with parents with serious persistent mental illness or who have child protection involvement, which kind of raises the bar for the trauma and mental health challenges we're seeing in our kiddos. And what happens is that primary care providers and other healthcare team members really need to be able to manage these increasingly complex healthcare needs. Wilderness Health focuses on the quadruple aim. So we try to figure out how can we enhance patient experience, work on better health outcomes, lower the cost of care, and have an improved care team experience. And we kind of see those flowing together, being part of a system. They're not mutually exclusive. Um, we are collaborative of independent healthcare providers. Some of these hospitals do have relationships with one another, but in general, this is not an ownership structure. They are members. And you can kind of see the reach across Northeast Minnesota and Northwest Wisconsin. If you're familiar with Minnesota, as far south as Carleton County, all the way up to Cook, and then out to the west, all the way to Itasca County, and then a few counties over here in the northwest corner of Wisconsin. And these are formal members. And then what we like to do is work with other providers around the region to kind of expand the reach. Um, Access and innovation, which includes telehealth as one of our strategies, is one of our key areas of effort. I probably don't have to preach to the choir about telehealth here, but we can bridge geographic barriers. We can get more access to different types of providers using telehealth. I do want to mention a few different funding sources. We've been fortunate to have been awarded 2 HRSA Rural Health Network development grants. We also support our work through a Minnesota Medicaid Integrated Health Partnership, which is like an ACO for Minnesota. We also work to connect through having a regional contact and provider list. We share coordination details for organizations that do share their information. And that way, if you're a care coordinator at one member hospital, maybe you can then connect with a care coordinator at another hospital, or you can connect your patient with maybe an independent non-member mental health provider. So what you're going to hear about today, we're going to hear from Dr. Carrie Rango. She's going to tell you all about True North Psychiatry, her practice, and unique ways to support children and families through telepsychiatry. We're going to hear from Shauna and Stephanie about Charlie Health. They have an intensive outpatient program, which is telehealth only, which serves children. They also serve adults. We'll talk about kids today. And then Wilderness Health programs. So we've got our ambulatory telehealth, kind of dub it our matchmaking rapid mental health program, and partnerships and collaborations. So I am going to go ahead and turn it over to Carrie, and I have a few slides for you, Carrie, so you just let me know when you want me to change the slide.
Sounds good. So my name is Carrie Rango. I am a psych mental health nurse practitioner. I have my family certificate, so see people across the lifespan. I also have my doctor of nursing practice. I opened True North Psychiatry in 2021, kind of in the midst of COVID, though the footprint was already laid prior to COVID. But my goal with True North Psychiatry is really to open up access to people who might not otherwise have access to mental health care. So the working parents who don't have the paid time off where they can leave work to pick up their kiddo from school, to bring them to that brick and mortar clinic, to do that appointment, and then to kind of repeat that whole process every time that kiddo needs to be seen. True North Psychiatry is set up using telehealth to bring parent and kiddo together from wherever they are and be able to provide that care with much less movement on the part of the parent and, hopefully a greater sense of ease without having to have that movement. I do see adults as well as kids. Kids in my practice do tend to have kind of a complexity about them. They're not, the typical kiddos. They get referrals from primary care providers when they're not certain how they should be handling those cases. And so I do, as Obi mentioned in one of the other slides, see a lot of kids that have parents with complex mental health needs, complex medical needs, as well as CPS involvement. So the kiddos can be just as complex as the parents and the parents as the kids, kind of both ways. I think you probably could flip it, Zomi. So my services are all telehealth. I don't do anything in person at this point in time. I work directly with parents and kids. I also do some provider to provider consultations, and that can vary in terms of what it looks like. Some provider to provider consultations are working with primary care providers or pediatricians to help troubleshoot things that kids are coming in with. Some of that work was done through curbside consultation, where I would sit for an hour and we would invite people in to have consultations, bringing clients forward. We could discuss the specifics of a case and then make some recommendations. Some of this is done on the backside through that mental health care practice, reaching out to primary care providers with concerns I have, primary care providers reaching out to me with concerns that they have. But also then expands to the therapy side of things. A lot of the kids I see do also have therapy providers. And so having that ability to consult with those therapy providers to come together to make sure there's not things that we're missing from a diagnostic standpoint, but also to make sure that we're both very well aware of what the kiddo is reporting for symptoms, what parents are reporting for observations, and taking a team approach to managing those things with that family. So those are the kind of the services provided. I find in my work that telehealth does work well for kids. Prior to True North, I was working residential treatment for a boys and a girls residential program and made the flip to telehealth within that program. And what I saw from in-person moving to telehealth was that kids were more willing to share things with me when I was on the screen. They also had more option to share things with me. They got a tablet for that visit, and so they would take me to their room and show me their artwork. And I felt like some of those conversations could be richer and I could challenge them a little bit more in terms of symptoms and what I was asking. I do see that still today in telehealth with my current setup. I like it because it meets the kids where they're at. If I have a kiddo that's got ADHD and they need to be laying on the floor, then you know what? They can have that tablet, they can have that phone, they can be laying on the floor, they can be coloring or doing their Legos, they can do whatever they need to do to feel like they can have that conversation for me. Sometimes, if I have a kiddo that maybe isn't as invested in that conversation, there's some anxiety there, there's some opposition there, they just don't want to see me that day, I bring in pets. I have a German Shepherd that is trained as a therapy dog. I also have a cat. He has no official training per se, but he's really good at coming in and sitting on a lap and looking at the camera so that that kiddo is kind of in tune to that cat and what they're doing. And then a lot of times I can ask my questions and they are far more willing to answer my questions if they're looking at a cat or a dog than they are if they're looking just at me or if mom is trying to make that happen. So I feel like telehealth can work with some creativity. My creativity, the side of that I use the most is the pets. And so there are definitely some successes. I've seen telehealth go from my kid has no access to services because I can't leave work to now my kid is seeing me, from school. They're doing well in school. They're engaged at home. We've done that by bringing them together in a unique way and taking out that brick and mortar piece so that it's attainable for everybody. So I think, that is very important. So I would say takeaway is From my perspective, telehealth is great for kids and adults. I know people have hesitation about telehealth with kids because they're not sure what that response will be. But my experience, my kind of creativity with setting up the visits for these kiddos has been really good. And so the takeaway is don't don't not try it just because you don't think it's going to work. Give it a go. Be creative with it. Think outside of the box. And I think you could be pleasantly surprised at the outcomes. I can say that consistently, the kiddos that I see have good outcomes. We're seeing good symptom control. We're seeing good things happening in school and at home. So we're seeing all of those good things happen, and we're making it work by telehealth and being able to offer that service wherever those families are comfortable. I think that's my only other slide, isn't it, Somi? I don't remember.
Yes. Yes, I just wanted to be able to look at this beautiful Maine Coon for
And he was just standing outside the door, but he walked away. Otherwise, I would grab him, but he's not right there right now. So I will let whoever is next do their presentation.
All right. Thank you. And I will just add that we have worked with Carrie in the past, Dr. Ringo, with bringing together our pediatricians with Dr. Ringo to talk about what's going on with kids in their practices. And through that, they were really able to build some more relationships. And, when you're referring somebody to another practice, knowing, what is that practitioner like, how do they work and what's the communication like and how do they operate? And so in addition to learning things about what types of medications and types of therapies and things like that, we had the opportunity to um, build those relationships, which are really powerful. So um, on to Charlie Health, and uh, I'll go ahead and turn it over to you, Shauna and Stephanie. You just let me know when you want me to flip your slides.
Perfect, thank you. I have, I guess, a lot of slides, but we're only going to briefly touch on some of them. So just general background. My name's Shauna. I'm with Charlie Health. I live in Cloquet, grew up in Two Harbors, so pretty much always been in rural, small town Minnesota. Um, and Charlie Health, I'm going to share just brief details on kind of how it started because I think it really fits in just with the conversation we're having today. So we started up in 2019, right before COVID. It must have kind of helped our trajectory because we are totally virtual. But basically, we're female founded. The founder's name is Carter Barnhart. She's pretty well known in the mental health space, but she had a best friend. The best friend's name was Charlie. Charlie lived in rural Montana, and he unfortunately died by suicide. And so, Carter said suicide is 100% preventable, and this happened because he did not have access to resources. And that, affects most people everywhere, but especially people living in rural areas. And so Charlie Health's mission has been to try to eliminate barriers, really, so that people, it opens up access for people to get care and get access to higher acuity mental health services. So just a few like barriers that we're kind of breaking down. We are 100% virtual, like I mentioned. We do not have a wait list, and that is our promise. We aim to never have a wait list. We want people to be able to utilize us when they're getting to that point of crisis. And so because of that, we know we need to be able to act quickly. We have very flexible scheduling, so, offering times in the mornings and at nights and on the weekends just to really work around whatever people already have going on. And then just for age range, we just expanded our age range. So I know we're just talking about adolescents and teens today, but we are ages 8 to 64. So we do see kiddos starting at age 8. This graph on the page here just kind of shows where we're at in the continuum of care. everyone's mental health journey looks a little different, and there's, not always a right way to go about it, but we are kind of in between inpatient and outpatient. And so I always say we could be really great for someone that maybe has once a week therapy, but they just need more support right now. They can, jump up, do our program, and then return back to outpatient when they're done. Or it could be really great for people that are coming out of the ER, inpatient, partial hospitalization, any of that. We kind of fill that gap in between. Um, and then the next slide, I know, shows just a few kind of specific examples. So just saying Charlie Health could be great for someone that already has services, but they feel like they aren't making progress. Someone that feels that maybe they're getting to that point of crisis, or maybe someone has services, but their family is very involved and their family is feeling like they really need support and they need an outlet. Um, Next slide. This just kind of shows Charlie Health. So it is wraparound care. We're flexible in pretty much all ways. We want this to be accessible. So there's not many requirements with our IOP. So, if you're going to be in our program, we want you to participate in the group and the individual therapy. But things beyond that are optional. It's kind of a la carte in a sense. So, if someone is coming to us and they are not receiving medication elsewhere or they're about to run out of their meds, we can step in and we can assist with that. We also have family programming. Family involvement is so important to us because we know that it makes a huge difference in people's recovery and their healing. And then we have support groups and crisis care and things like that, just trying to offer wraparound services. Next slide. This again just kind of drives the point home for the family support that we offer. And it is chosen family. So, whether that's aunts and uncles or grandparents or whatever it may be, we welcome them to join in your treatment here at Charlie Health. And the next slide. So just talking a little bit about what this could look like for a family or for the kiddo in our programming. Um, this offers a look at kind of the different lived experiences, different conditions, different insurance, different schedules, and just showing how we can kind of meet their needs. I know especially with kiddos, a lot of them, they have school in the day, then they have sports. They can fit us in after. They can do programming at 6 o'clock or 7 o'clock or whatever works for them. We can fit appointments in on a Saturday if they need to. Um, so that just kind of breaks that down. But then the next slide shows what we think is so special about Charlie Health, and that's just how we are so customized in how we do our grouping. And so we factor in, of course, their condition and their age, what treatment will bring the best clinical outcome for them, but then we also look at lived experiences. And so I always think about someone in rural Minnesota. They may be a teen. Maybe they identify as LGBTQIA+. Maybe they have a history of sexual abuse. We will be able to group them with other teens coming from rural Midwest that also identify as LGBTQIA+ and also have shared lived experiences. And so that is huge for someone, especially in a rural area, because visibility can be so low. There's not much representation where they're coming from. So being able to connect them with others that, have gone through the same thing, so that they can connect, we know that that makes a huge difference in someone's recovery as well. So we offer many different kinds of groups. We have groups for neurodivergence and for LGBTQIA+ and military families, maternal mental health, things like that. We have several different groups. The next slide. Oh, so moving on to kind of the results. Um, what we do at Charlie Health, I don't know any place else to really do it, but we focus very heavily on what we call measurement-based care. And so we are always doing the assessments, the WHO-5, the GAD-7, the PHQ-9, all of those. And we're collecting data at every appointment, every week, and we really show all of that data and use it in individual sessions with the client. We want them to see their information and their data and where symptoms are improving or, what their progress looks like in their journey with us. And in doing that, since we've moved to this measurement-based model, we have seen satisfaction rates went up 10% and attendance rates went up, I think, 3 to 4% as well. So people are feeling empowered in seeing the results, seeing what's kind of going on statistically while they're in our program. We are very data heavy here at Charlie Health. And so when we're talking about our outcomes, we do partner with Yale and UPenn to do all of our outcome studies. And I can provide any of that information to people that, maybe like the data part of stuff. But as you can see on the screen here, just showing people when they admit into Charlie Health, kind of where their scores are as far as their GAD-7, PHQ-9, and how those symptoms have decreased, at discharge, 3 months post-discharge, 6 months post-discharge. So we're seeing some really great things happening, obviously, across the board. We're showing a decrease in suicidal thoughts, anxiety, depression. The next slide shows just satisfaction rates. So 91% would recommend Charlie Health to a loved one. So we're really happy with these scores, of course. And then on the next page, one stat that I always talk about, it's so important in the mental health field, talking about the revolving door. And so we all want to stop that revolving door, right? I talked to a lot of ERs about people that come in and, maybe they're at that point of crisis and maybe it's not severe enough to admit them or hold them. And so they discharge them on a safety plan. And so then what happens is, maybe they leave and they're out in the wind. They could relapse or they could go back to their unsafe situation. They're still in crisis and likely they're going to show up again in a week or two. And so we really want to focus on readmission rates and lowering them. And so for people that have completed our program, 1.7% of all Charlie Health clients readmit to a higher level of care within 6 months of discharge, which is significantly lower than the national average. So we're really proud about that. It's showing that people are coming to Charlie Health, they're healing, and it's long term. So just to circle back to the ER and the safety planning, I always say, Charlie Health could be a great way to intervene there in that step. If you're sending somebody out on a safety plan, that is probably a great candidate for Charlie Health. So really what we're just trying to do is fill gaps in the continuum of care. We are episodic care, which means that we are temporary. And so for people that want IOP, they can come and do our program. It's usually about 8 to 12 weeks. 12 weeks is kind of the max. But we can also act as a bridge. So for people that maybe are waiting to get into treatment or they're just waiting to get testing done, and it's going to be 3, 4, 5, 6 weeks wait, they can do our program in the meantime. So at least while they're waiting, they are getting that high acuity support, which is so important. So, yep, we're just trying to fill gaps that are there. We are not long-term, we are temporary. And so because of that, we're trying to work really closely with other partners that are already in the community so that we can pass people on once they're done with us or if they're not a good fit for us and things like that. Um, that was kind of my spiel. I feel like I took more time than I was supposed to. So, here's my info. If you want any more data, information, anything, please text me, call me, email me. I would be happy to connect with you, send you whatever you need.
Thanks, Shauna. I think one of the ways this has been really valuable for Wilderness Health and for our region is just what Shauna was talking about filling gaps. There are very limited intensive, either inpatient or intensive outpatient services available for children in our area. And so to be able to have something that bridges that gap between um, kind of even a hospitalization or even waiting for an intensive outpatient spot is really valuable, and for families to not have to be traveling hours away to get to services. So just another way that we kind of are looking at how our providers across our region using telehealth to kind of make sure that the patients in our region are cared for across that continuum. And just having this program by telehealth, I think, is really unique. There may be other programs around the country, but this is the first one I've really seen in action. So, all right. I'm going to talk a little bit about some of the efforts that we have done at Wilderness Health. Some pieces around programming and process evaluation to support our members, and a toolkit with some outreach and supportive guides. I think I'll probably take about 10 minutes here, and then that way we can have some time for Q&A, and then if we end early, you can have a few minutes back in your day. We have some active programs. One of them is, we call it different things on different days, but it's officially, I think, the Rapid Mental Health Assessment and Therapy Program, which serves primary care and critical access hospital sites, and this is in partnership with Adaptive Telehealth. In previous efforts, we have worked with an ED telebehavioral health pilot, providing a psychiatric nurse practitioner to two critical access hospitals. And these services are there to support both children and adults. And today I'll focus more on how they can help children and teens. We also, I mentioned, had curbside consultations with Dr. Ringo, which were very helpful, especially for our pediatrician medical director at that time. And we've done telehealth process mapping and process evaluation, best practices, consultations to be able to help our member hospitals in doing their own internal telehealth practices when requested. So this rapid mental health assessment and therapy program kind of came out of some conversations we had with one of our critical access hospitals that does have a clinic, and many of the clinic providers are saying, my goodness, it is so hard. We're getting so many patients coming in with sort of dysregulation. How do I know if this child has ADHD or anxiety? And oftentimes it's more complicated than just, is it anxiety or ADHD? But that seemed to be the question that kept coming up over and over again. Of course, we know there are other pieces there like trauma and other types of conditions. And, they have patients asking for medication. They could be nurse practitioners, PAs, or family medicine doctors, all in this family medicine space, and feeling like they really needed some more, they identified some need for some more resources. So that was kind of the impetus behind this. And it is, I haven't looked at current stats, but not everyone needs psychological testing, but oftentimes people are referred to psychological testing, and if they are, it could be like more than months, like maybe a couple years, sometimes depending on the spectrum of the test that's being requested. Some people can go ahead and get some help with starting with the diagnostic assessments. We wanted to go ahead, and that's where this rapid piece comes in. So we've got Minnesota licensed behavioral therapists, and patients can then continue with that provider. So one use case would be a patient is referred by their primary care provider. It's now being used actually a lot out of one of our Duluth clinics. Please, evaluate for ADHD and sends back a report. And so that happens by telehealth, and the provider gets a report back, and they can then figure out, does this person need continuing therapy? Do they need medication? Do I feel comfortable prescribing the medication? Kind of get people on their journey. Additionally, this is available for critical access hospitals two of them, Ely Blumenson and North Shore Health, in very remote areas, to be able to get quick access to a therapist, kind of through a therapy matchmaking system, so you don't have to wait. And so sometimes patients might go ahead and start with that therapist, and that's short-term therapy until they can get someone physically in their town that they might want to go see. So even some of the CCBHCs are up to 8 weeks for therapy in some of these regions. A slide here about kind of what use cases are available. So we talked about diagnostic assessments, short and long-term psychotherapy, and utilization can work for both primary care sites and then hospital sites. And what we've tried to do over time is, hey, we started this program, this is what the need is, and tried to build in new processes and programs. That's what we're always trying to do, is figure out what our community is wanting and needing. Here are a couple of our therapists. We just have had some coming and going, but these providers have actually had patients start to be seeing them on a long-term basis. And I didn't bring the numbers with me today, but we've actually saved a lot of patient miles from. There's one patient, I think, in one of our most rural areas that has seen one of these providers many, many times, and that has saved them quite a bit of drive time. I'll talk a little bit too about our community outreach and education, because I think this has been an important role for Wilderness. We're not a service provider, and we're out there trying to bring hospitals together. We brought in a marketing firm, and then we brought together community members, and we brought together members from our hospitals to kind of create some personas about how we could reach out to people about telehealth and how they could use telehealth. And this has evolved over time. And although telehealth has certainly become quite a bit more, popular and more frequently used, especially since COVID, there's still many community members and communities out there that are thinking things like, this doesn't work for kids, or it doesn't work for this group, or it can't work for me, or it can't work for this, or it doesn't work for therapy because it's not personal enough. And so trying to figure out like where that messaging can be used. And so we have some personas that are sort of around that pediatric population. So we have our Finley with this emerging identity, teenager, and Teresa, a concerned parent, hearing a lot of worry and concern from parents in our region about what's going on with their kiddos. We do have some videos too based on those personas, which get this presentation you can click on. I'll skip them for today. We do have a number of outreach materials available on our website for our community, but some of these are also pretty broad and can be used by, I think, anyone. So we've got a patient guide. We created a Doxy and a Zoom virtual guide, and the rest of, hospitals and providers may be using a number of other applications. So these were some common ones that we were hearing about. And we also have a provider guide. If you are a clinic or a provider who wants to get telehealth set up for your site and want to figure out where do you start, you can go there. We also created some items specific for kids and families. This brochure, you can click and get this brochure and print it out for your sites if this is of use. And it kind of talks about how a diagnosis can help get your child support in school. Oftentimes people are coming into therapy or to their pediatrician or coming into the healthcare system saying, the school said that I need to do something with my child. And that's a really stressful place to be as a parent. So what do you do? Like, is there something wrong with them? Is there something wrong with me? Like, what's going on? How can I help support them? And so here are just some steps to kind of get that going. And then how can telehealth help with this process? So you can get a diagnostic assessment. Yes, there are always going to be some cases where a full diagnostic assessment is not appropriate for a certain person, but a lot of times it can be done by telehealth. Additionally, wanted to share a little bit about how Wilderness is kind of thinking about how can we look at telehealth in our region into the future. And we brought a graphic designer in to one of our care coordination sessions and said, all right, care coordinators, there's social workers and RNs and care navigators, and said, hey, what if you dreamt big? What could telehealth look like in our region? And who is it going to serve, and what are we going to do? And so people came up with some really cool and interesting ideas, which not like Wilderness isn't, in a position to implement all of these, but we absolutely refer back to this and we share it with groups like this because then we hope when we're sharing this vision, right? So, you can use it for pediatric patients, which we're here to talk about today. Um, ER support, especially for maybe our critical access hospitals, having little pods, just like breastfeeding rooms, having a little telehealth pod where you could have your visit out in public areas. Um, Making sure that you can kind of think about telehealth for care coordination. I mean, that's one of the biggest pieces that we work with our members on is how are you coordinating care across different services and across the continuum. What if you had some things that were available 24/7? Children and new moms, and I think we could probably all agree that if we are supporting our parents um, as on their parenting journey, that we're supporting our kids as well. And also kind of recognizing a need for tele-liaisons because there's still a need to try and figure out, well, how do I navigate this and how do I get into my patient portal to get to the visit and all of those kind of technical pieces. So I'll close here. I I know Mary, you said that there was a Q&A tab, so I guess I'm curious if there's anything in the Q&A that our panelists can answer.
At this point, there is not, but I do open it up for those that are attending. If there is a question that you would like to ask live, as opposed to typing it all in the Q&A, please know that you can just raise your hand and I can unmute you. And so that is an option as well as the Q&A option, the Q&A tab. So know that we will pause for a little bit so you can either build up your courage to ask the question or put the question that you have in the tab. One question that I have, I guess, Zomi and team, is so is the services that Dr. Rango provides and the services that Charlie Health provides, are they combined or are they separate and they serving different groups?
So I would say that a patient could utilize Dr. Rango's services and Charlie Health services and primary care from Wilderness Health. I wouldn't say that we have like an established like protocol that we always do it this way or that sort of thing. So it's just sort of trying to show different ends of the continuum of providing that care.
So you have organizations across Wilderness Health who are tapping into both of these services based upon the needs of their clients.
I would say so. Yeah. So for example, Shauna, you could probably rattle off all that you've really been hitting the road with talking to our members, which is awesome. You've talked to North Shore Health and you talk with the maternal child health department at Spire St. Luke's, for example. I know that Mallory was so excited to talk with you to be able to have kind of yet another resource to be able to fill in that continuum of care. So sometimes we're having to craft a continuum of care for patients because it's not like, oh yeah, this member hospital has, intensive outpatient for kids and they have therapy for kids. They've got all these psychiatrists for it just doesn't work that way. So we're kind of having to craft things together.
Great, thank you. Yeah, that's helpful. We do have a couple of questions now in the tab. The first question is from Tara. Do you have recommended self-help apps?
I'm curious. Shauna or Carrie have ideas on those?
I don't have any that I regularly recommend for kids, but I think one that could be applicable to kids, I have some adults that are using too. It's called the Finch app, and it's actually like a bird that you take care of. So as you're feeling it, like how people are using it, as they're feeling really anxious or restless or feeling like they need a break, they'll open that app. They'll hang out with that bird and feed it and give it water and do all the things that they can do with it. And then that transitions their brain from whatever was causing that symptom to like this app. And then they can kind of take a breath and move on to the next thing. So that one is one that has gained popularity a lot, I would say. Even in the last month, I'm hearing more and more people are using it. So something to go and check out.
I too have heard good things about Finch, and I talked to someone who said you can make lists on there, like if you have a to-do list, and then if you check them off, it kind of helps you get points or something towards caring for your bird. So if you were a Tamagotchi person back in the day, it's similar to caring for your Tamagotchi.
Wonderful, wonderful. Thank you. I'll be interested in digging that up and seeing what that's about myself. So, we do have another question, a couple questions. Mark is asking, is there a statewide program in place that coordinates on-demand delivery of service to patients that show up in the emergency rooms of community and critical access hospitals in Minnesota? Or are the programs discussed on a regional basis? Denise,
I
I
am
guess
not
that's for you.
familiar. Yeah,
Yes.
I'm not familiar with. There may be some. There was a statewide PAL psychiatric assistance line where you could connect. I think it was run by Prairie here. We connect with a psychiatrist. I am not sure how many people are using it and or how useful it is in each of the rural settings. And so I think there's a lot of piecemeal things going on. So Avell eCare and their sort of psychiatric, either their add-on, usually they're add-on to the ER service or as part of the ER service, and having a psychiatric nurse be able to um, assess and see if do a safety assessment and see if placement is needed. That's available, but it is not like a statewide service. That's just happens to be one of the more common services that people are using. I don't know, Carrie or Shauna, if you know of anything else.
There is a website. It's called fasttrackermn.org that I mean, the organization has to list themselves on it, but it's my understanding that people can go search that site for behavioral health openings, whether it be on the medicine management or the therapy side of things. So I imagine that's something that a critical access or an emergency room setting could access that website while that client is there to give them some options in terms of therapy or med management evaluations, because I know my practice is listed on there, and then I have to go in every week or every 2 weeks and update my availability so that it's current to how far out my appointments are.
Ah, interesting. Okay, thank you. Thank
Yeah.
you. Next question is, do you have experience with prescription digital therapeutics and billable RN care management? And then maybe experience with
Yeah.
remote patient monitoring too.
I have to think about that one. I I don't think any of our member hospitals are doing this, or if they are doing it, they're not doing it on a widespread scale. So I'm curious for Carrie or Shauna if you know of anyone.
I'm not using any of the remote patient care monitoring devices. I'm not sure what they mean by the prescription side of things. I mean, everything that I have to prescribe is electronic, and that's where pharmacies have kind of shifted now. But beyond that, I don't have any info to share there.
I'm going to just add, I'm Stephanie, by the way, I'm Shauna's manager. I'm just here for support today. But we do, through the Charlie Health program, we know that safety obviously is an issue, especially in virtual care. And we do have what we call Charlie Care coordinators that are monitoring the rooms. And if we ever see somebody that is having, maybe a safety concern, we will pull them out into their own private room and try to stabilize them, I should say, and then get them back into the program. And if there is something that's a little bit more serious, we have a safety plan that we have with every patient that we will enact immediately if that is needed. So I don't know if that answers your question, but we do have monitors monitoring our rooms outside of just the therapist.
Great, thank you. If the person who asked the question, if we didn't get to what you were looking for, I guess clarify a little bit further in the Q&A. The next question that we have is from Megan. She says, in our area, caregivers of kids are generally reluctant to consider telehealth for their child. Wondering if you have 2 or 3 ideas that may fit to promote telehealth with caregivers. Yeah.
It's hard as a parent to put your kiddo in a telehealth situation, I think, especially if you don't have experience with it yourself. I think that, in terms of ideas, I wish that I could say that brick and mortar was the wave of the future, but I think that brick and mortar will continue to lose popularity as telehealth gains popularity. And I think, talking to them from a convenience standpoint is a big thing. Like this telehealth opportunity gives you the access to a provider without having to leave your office space, without having to pull your kiddo out of a classroom. Like you can come together for that one appointment from different places. It is opening access. So sometimes telehealth providers have more access available for appointments. I try to keep a couple of new intake openings in my schedule available so that I can get people in faster than like right now in the community, we're looking at probably 3 to 8 months, depending on where you're looking for services for mental health overall. But for kids, it's longer because the number of providers that are seeing kids are fewer and more far between. So I think, also the whole environmental, like your kiddo can be in a comfortable spot. Your kiddo can be laying on your couch in their room, having their stuffies, having their own pets with them. I think, the access to care, but also that comfort level with that care is much higher from a telehealth standpoint because they can have a comfort place and comfort items and all of those things available to them as well.
I would add that if you're looking for tools, we have a simulated video of what our services look like. So we actually have like group sessions that we can share with you on a video link to show them this is what the experience will look like. The rooms will be 4 to 6 people. These are some of the concepts that we're talking about and how people are sharing. Unfortunately, I know we're talking about pediatrics today. They are like young adults that are in that video, but at least it will give them something to kind of understand better what telehealth looks like from a video perspective. And it's 3 minutes long.
2 things that usually I add as well is when we've been successful with thinking specifically juvenile detention, they talk about a lot of times in a group setting, people will come together, do these groups, participate in the treatment. But then unfortunately, they'll often leave the group together and maybe fall back into the same patterns because they're forming these strong bonds. And then, the cycle kind of continues. Whereas in a telehealth setting, it does kind of remove the risk for, safety issues or potentially, yes, falling back into those same patterns with the new connections that you do make. But also just our ability to bring people together across a larger scale. Like I said, getting very specialized, because in rural areas, there's low visibility and representation. But then also something I found interesting, I saw an article and I've thought about it ever since. And a lot of times the discussion is in person versus telehealth. But I think the discussion should be telehealth versus nothing. Because really, if it's not going to be convenient for you, if you're going to have to commute, if it's going to be expensive, if you're going to have to take off work, it's going to make it so much less likely that you actually are participating in care. And so, really, the conversation at that point is telehealth versus nothing. So, maybe framing it in that way as well.
And then I was just going to add one more thing. One thing that you were talking about earlier, Shauna, is there is a stigma with mental health as well. And with our programs, I don't know if you mentioned it, but we're in 37 states. We're the largest virtual IOP in the nation. And usually when you're in your IOP with Charlie Health, you're not going to be in it with anybody that you know. You could be in it with somebody from Chicago, Minneapolis, Green Bay, Wisconsin, but they can take their programming that they absolutely need in private where nobody will see, them show up in their car and, the clinic's driveway or, things of that nature, that sometimes that stigma really is a problem for kiddos and even their families.
Yeah, I think those are all really great points and great examples of some things that could be used to help caregivers kind of understand how and why this can be a good thing for their kiddo. So any other last call for questions here? We've gotten through the questions on the list. I'll pause just a moment. All right. Well, thank you so very much for this this great information. This was a great session. As I mentioned, this is being recorded and it will be made available following this session. As I said, give me a day or two to get the recordings all pulled together. And then giving you a heads up that the fourth and final one of the summer we have a topic for next month. Will be pediatrics in rare diseases and dermatology. And so that will be the topic. We will have more information coming out. I'll look for it in the newsletter. And with that, and if there are no other questions, I'll check one last time. Then we are good to go. And I thank you all, Zomi, Shauna, Carrie, and I'm sorry, all of a sudden I've just blanked on
Stephanie.
Stephanie. Thank you. I was like, okay, wait, I know it. But thank you all for sharing your experience and your background and your programs with us this morning, afternoon, I guess it is. And have a wonderful day, and we will look forward to seeing you all next month. Thank you.
Thanks, everyone.